on Mycobacterium tuberculosis, the causative agent of TB. So a bit of a global perspective on tuberculosis. Tuberculosis is one of the world's deadliest diseases. 1/3 of the population is infected with TB. So if you imagine there's 7 or so billion of us on this planet, you can do the math. Each year, about 9 million people around the world become sick with TB, and there's about 2 million TB-related deaths worldwide each year. And about 250,000 of those deaths are children, which, again, is surprising to me that we've reacted the way we have to COVID, but meanwhile, tuberculosis just burns like this year after year after year without us doing anything about it. TB is the leading killer of people who are HIV infected. So as far as a little bit of history, Hippocrates is probably the first one to actually describe TB. He called it phthisis, which is basically a Greek word, but that probably roughly translates to consumption. It's a reflection of the fact that the microbe consumes the body, and that's what it used to be called. Even in the 19th century literature and so forth, they would call it consumption as a way to indicate that the microbe doesn't just sit in your lungs; it can actually consume you and grow anywhere in your body. In 1882, good old Robert Koch identified the causative agent as the tuberculosis bacillus, and I talked a bit about that in the first history lecture. By 1921, the first TB vaccine was developed, and it was an attenuated strain of bovine tuberculosis. So it's one that doesn't really cause severe disease or at all in people. And so they used this weakened bovine strain, and this vaccine is called BCG after the French scientists. It's still used in some countries. We don't use it in the United States, but it's still used in many countries through their vaccine campaigns. In 1946, the antibiotic streptomycin was discovered and became the first effective treatment for TB. And so this antibiotic quickly was shown to be weak in terms of destroying the microbe because it was a single therapy, basically. And that's why the microbe was able to eventually develop resistance. It's a slow-growing bacterium that, if you try to hit it in one spot, the microbe can eventually evolve resistance. And that's exactly what happened. And so multi-drug combinations began to replace streptomycin. And of course, people realized that because it's a slow grower, he needed a much longer course in order to treat the infection. The obviously the longer course, in addition to the microbe, in addition to the lack of combination therapy, the length of therapy required often included a lot of discontinued use. People just forget to take their drugs or whatever. And so that provided additional opportunities for the microbes to become resistant. By the 1980s, all of our TB surveillance programs had kind of been shuttered or defunded and all that. And then, of course, with the emergence of HIV, you have this huge population of people with immunodeficiency, which allowed TB to reemerge. And now we have these strains of multi-drug resistant and extensively drug-resistant tuberculosis. By the 90s, it was declared a global health emergency, again, due to our complacency. Some of the patterns of infection, as you see here, the primary tuberculosis is small granulomas in the lungs, as you see here. Granulomas are basically these types of immune responses in which you have a bunch of dead cells, lung cells, immune system cells, dead bacteria, and so forth that are walled off by components of your immune response. But that tissue just dies. And so you have large regions of your lungs that are dead and walled off. There can also be live microbes in here as well. So it's not like the microbes just lose the fight. They just kind of go into a very, quiescent or dormant state and don't grow very much. So that's why you have long periods of time often between individuals having acute tuberculosis and then it reemerges. It's almost, it's like a cancer in a way where you can go into remission. So we also call these things a Ghon complex, or a calcification, which basically is a tubercle. So there's a couple different names that you might hear, but tubercle tubercle is the primary term, and granuloma is more of a technical term. But generally, it's just calcified, walled off tissue that you see here. And again, when this happens, the lung loses its function. Secondary tuberculosis is a reactivation of the bacteria, and typically it's followed by or preceded by caseation or liquefaction, where the microbes start to grow, and apparently they, again, start producing digestive enzymes, and obviously the immune system reactivates and starts killing tissue as well, and trying to kill the microbes. And so this process of the microbe degrading tissue and the collateral damage from the immune system cells results in this liquefaction, where the microbes can spread. Essentially, they can ooze from these granulomas, and then basically irritate the lungs and stimulate a coughing response. That's where we get this other version, miliary TB, where it spreads to other organs, and that's where that initiates the systemic infection, and that the reason why it's also called consumption. So this is a primary diagnosis is looking for tubercles in TB patients through a chest X-ray. Another thing that's done, and usually the first thing that's done, is a sputum or phlegm collection. In this particular case, you collect things in the morning as soon as people get up. You can you clean your teeth a little bit and rinse and rinse with water just to get excess oral microbes out, and then you spit that sputum straight from your lungs, that dark green bloody nastiness into a plastic cup, and then you can dip into that and use the something called an acid-fast bacillus or an acid-fast stain, AFB or AF or AFB stain, for acid-fast stain. Or there's a fluorescent stain you can use as well. In the acid-fast stain, the microbes are stained with a particular dye that selectively sticks to them and can't be washed out with your decolorizing step, because they have a very special envelope, which I'll talk about. You can also culture the microbes on a medium called LJ medium, but it takes a long time for these guys to grow. So here's a look at the acid-fast stain, and again, the results would be these long, thin, red rods as a result of acid-fast staining. So again, the idea is that you treat them with this red dye and then decolorize them really vigorously. But because they have a very waxy coat, they hold on to the dye, and other microbes will not. And so therefore, these guys will remain red, and other microbes will stain with whatever counter stain you use, preferably something that's not red. Anyway, this is an actual mucus smear, and so you can see a lot of the eukaryotic cells, but these little red thin rods, they're almost purple in this. Obviously they're red, but the bluish counter stain kind of, anyway, causes them to be a little bit more purple. But these little blobs are the mycobacterium intermixed with all the eukaryotic cells and mucus. And so one of the reasons why that works, that acid-fast stain works, is because the microbes have a lot of wax in their cell membrane, cell envelope rather. And so they have a compound called lipoarabinomannan that you see here, this glycolipid, and then they have this really strong waxy layer called mycolic acid, and then arabinogalactans, these sugars here, which stick that form a linkage between the wax and the cell wall. And then you see these manophosphoinositides. So again, these collectively are glycolipids that make this very waxy. If you grow these guys in culture, they're very they're very waxy. They're like candle wax, almost very hard to pick up with a inoculating loop and so forth. But the benefit of having these, if you're a microbe, is to impede the entry of chemicals. But the problem is having these glycolipids results in slow growth, because they have to build all these carbon-rich molecules on their surface. Another good thing though is, obviously impeding entry of bad chemicals is a good thing. It enhances resistance to toxins. Making sort of a impenetrable shell on your surface means that certain toxins can't get in. And that's why it's hard, you need special disinfectants, for example, to clean them in the environment. Glycolipids can stimulate an inflammatory response. So some of these molecules, like lipoarabinomannan, when your immune system recognizes that, it sets off the immune response, and that can cause additional damage or an inflammatory response. So as I said, they look very waxy on media, and this is TB colonies on LJ media. Remember, it takes 2 weeks or so for these to form colonies. Oops, geez. The composition of LJ medium is has some egg yolk in it, which is obviously a source of rich lipids that the microbes need to grow. Starch, which is a rich source of carbon, and glycerol is also a carbon source. Asparagine is a carbon source, but mostly it's there for nitrogen. The microbes have a nitrogen requirement, not surprisingly. And then because they're so slow growing, you've got to put some selective agents in there, or else the faster growing weeds in those mucus samples and stuff are going to actually outgrow them. And this little chemical reaction here just shows you how the microbes use this process called beta oxidation to break down fatty acids, like the fatty acids in egg yolk or the fatty acids that they would have available to them in your lungs. They produce 2-carbon-acetyl-CoAs, and each of these 2-carbon-acetyl-CoAs can then be shunted into this glyoxylate cycle, which allows them to generate energy, but also to make more of the wax and other glycolipids. So here's just a quick look at the glyoxylate cycle. And so again, the acetate, the acetyl-CoA that comes in from the breakdown of lipids in your lungs or on LJ medium from the egg yolk is combined with the 4-carbon oxaloacetate. This is just the TCA cycle, a Krebs cycle. But the tuberculosis bacteria can use this glyoxylate shunt that you see here, where they make the 6-carbon citrate and they isomerize it to isocitrate. But they have this special enzyme here, isocitrate lyase, which allows them to convert isocitrate to glyoxylate and ultimately to malate. And then at this level here, the malate can be shunted off to make pyruvate and then backwards to make glucose. So this is basically like a reverse glycolysis, where they take the malate and send it backwards to make sugars. And these sugars are essential for making these, to help make these wax layers. So the microbe doesn't want to always do this full TCA cycle. It will want to do it at sometimes because it makes energy down here. But the microbe will want to avoid these extra steps because of these decarboxylation events. They're losing carbon, and they need all the carbon they can get. So they develop this enzyme to shunt some of this carbon this way so they can make sugars out of it rather than lose those carbons here. So non-pathogenic bacteria, when they're phagocytosed, will stimulate the appropriate response, intracellular response in phagocytic cells, meaning that an early phagosome will form, and then these endosomes will fuse with lysosomes. These lysosomes are full of toxins that will then fuse with these guys and then kill the microbes. But pathogenic microbes, as you see here, for example, will interact with these receptors, and they have the capacity to block these signaling molecules. And by blocking these signaling molecules, so I didn't point this out, but these signaling molecules, sphingosine kinase and phospholipase C, for example, elevate intracellular calcium, and that high level of intracellular calcium encourages this fusion here. But if these things are blocked by the pathogenic microbes, you don't get that fusion. This lysosome never attaches to this to kill this guy. And then this guy can grow in the phagosome and then eventually break out and then persist and grow in the cells. This reaction over here is a relatively recent research showing that the microbes can activate coronin 1. And somehow coronin 1 and an interaction with calcium and calcineurin will interfere with that late stage phagolysosome formation. Here's a possible model for how that might work. The microbes, the microbes are taken into this phagosome, as you see here, and then that somehow the coronin that you see here actually surrounds the phagosome and prevents the lysosomal fusion. But again, the mechanism is a little dodgy at this point, so I'm not going to get too deeply into it. But I just wanted you to see that there's a potential other mechanism through coronin in addition to blocking sphingosine kinase and phospholipase C. So just a quick tuberculin skin testing overview. This is another method. Obviously we can do the sputum testing that I showed you under the microscope with the acid-fast stain. We can grow the microbes on LJ medium as another example, or you could just do a chest x-ray or a combination of those things. But the tuberculin skin testing is pretty routine, and most of you probably, or many of you probably have already had this done. In this particular case, you inject something called PPD, purified protein derivative from the bacteria, just under your skin. After a short period of time, if you get an induration, reddish induration, or a hard bump that's about 10 millimeters or greater, that suggests that you're producing a localized immune response pretty quickly, and therefore that also suggests that you've been exposed to the bacteria at some point in your life. That doesn't necessarily mean you're infected currently with TB, but it does mean you've been exposed to TB, and therefore you should be tested more stringently for the presence of an active infection. If this happens, if this reddish induration greater than 10 millimeters happens later than this, like for example, when I had mine done, it was about a week later that I had that reddish induration and the hard bump. And so that was, obviously it was a negative result because of the length of time that it took for it to form, meaning that my body had never seen TB before, therefore it didn't have memory of TB and didn't respond very quickly. We get a lot of false positives in countries where BCG is widely used, and that's why we don't use BCG in the United States, because our tuberculosis prevalence rate is relatively low. And so therefore this diagnostic test is still very useful to help trace potential TB cases. But if everybody received this vaccine and then everybody then would become positive for tuberculin skin testing, then we would lose the ability to perform this surveillance test. Just a bit about treatments. As I said, it's a long course, 6 to 9 months. Usually it involves a multi-drug regimen, such as isoniazid, which prevents mycolic acid synthesis. So again, the microbe is prevented from producing an enzyme that helps it make the wax layer. And often in combination with something very different like rifampin or rifampicin. Either one, they're used interchangeably, rifampin or rifampicin, which is an RNA polymerase inhibitor that knocks out the ability of the bacteria to transcribe DNA into RNA. So again, hitting it in 2 different places minimizes the possibility of antibiotic resistance. But resistance to TB drugs can occur when these drugs are misused or mismanaged. And so there's a reason why that can happen, such as people don't complete their full course, which is very typical. Imagine, you get a typical strep throat, for example, the course of antibiotics is about 5 to 10 days or something. And how many times do people just forget just in that 5 to 10 day window to take a dose? So you can imagine a 6 to 9 month where you're doing this daily could be something that individuals forget on a regular basis. Again, wrong treatment, wrong dose. And wrong treatment usually just means they didn't take the time to figure out if there was any kind of resistance in the strain that the individual had. So if they treat a person with RIF and isoniazid, but the microbe is RIF resistant, then you obviously aren't going to get the full strength of the treatment. Wrong dosage. Not strong enough. If it's a multi or paucibacillary infection, you may have to ramp up the dose depending on the bacterial load that the individual has. And certainly the wrong length of time. This is a big issue in third world countries. Supply of drugs not always available, or the drugs are of poor quality. They're expired, for example. MDR-TB is multi-drug resistant TB, and that is defined as a microbe that's resistant to at least two of the best anti-TB drugs, isoniazid and rifampin or rifampicin. Extensively drug resistant, XDR, is relatively rare. Hopefully, is relatively rare. It seems to be more and more prevalent these days. XDR-TB is defined as TB that's resistant to isoniazid and RIF, plus resistant to any fluoroquinolone. So these guys interfere with DNA replication, and at least one of three injectable second-line drugs. So some of these other protein synthesis inhibitors, because again, these are typically the way it's done. It's done in the treatments are done in these cocktails. And so the idea that the microbe is extensively drug resistant because it's resistant to these frontline drugs, isoniazid, rifampicin, and a fluoroquinolone, as well as one of the next line injectables. And so I want you to watch this particular video. It's actually really cool, where where individuals have figured out how to use sniffer rats to detect TB positive sputum samples. The idea is to you have, instead of having to train, and it's not difficult to do, but instead of having to train people to do acid fast staining or to wait 2 weeks for culture positives, we can just somehow they figured out how to get these rats to detect some molecule, possibly mycolic acid, in a sputum sample. And so if they can detect the smell of TB in the sample, they can, the technician, all the technician has to do is just expose the rats to the sample, and if the rat reacts, they can, the rat identifies the sample as positive, and then they just feed the rat. So it takes away the need for a microscope and all that stuff to do acid fast staining, or even, a fluorescence microscope to do fluorescence staining, or any of those other slightly more sophisticated approaches. So please take a look at that video if you get a chance.